My dear friends, so a very hearty welcome to part 6 of respiratory medicine at the rate of Madicine. This time the topic would be pleural effusion, and let's have a view at the lecture of today, the various slides. A lot of work has gone into that and more. Okay. And of course the theory part. So let's start with the theory and then we'll keep having a sneak peek into the images. So pleural effusion, you need to tell me what is pleural effusion. It is the accumulation of fluid in the pleural cavity. So pleural cavity is that which is present between the visceral and the parietal pleura. The normal volume of pleural fluid is only 8 to 10 ml, but when excess starts to accumulate, the condition is called pleural effusion. This pleural effusion can have a different types of composition. If it is fluid in nature, it can be called hydrothorax. If both fluid and air, it is hydropneumothorax. If pus material is there, pyothorax. Blood, hemothorax. Cholesterol containing fluid, chylothorax. Okay, lymphatic, cholesterol containing fluid, chylothorax. So if we talk about the pathogenesis, like why on earth will a person develop pleural effusion? Yes, that is the question. Because what is happening, as you can see in this hand diagram, this PP is the parietal, VP is the visceral pleura. So in the parietal pleura is responsible for secretion of that minimal basal amount of pleural fluid, that is 8 ml, and all the time it is getting secreted from the blood vessel. This fluid is coming from the blood vessels. It is obviously a direct derivative of the blood, and all the time it is also drained by the respective lymphatics, that is costal and mediastinal. So there is a balance between the two, that is the inflow or the synthesis as well as the outflow or the efflux with the help of lymphatics. Now if this balance is lost, there is more of influx or more of inflow or more of synthesis and less of outflow. That can be a cause of pleural effusion. So, and another thing, as we have studied always about Starling's laws, Starling's forces, so we know that there is one thing called hydrostatic pressure and second thing called oncotic pressure. So if number one, there is an increase in the hydrostatic pressure, or number two, there is a decrease in the oncotic pressure, both these two can also cause increase in the fluid volume in the pleural cavity and lead to pleural effusion. So if I want to now summarize that, what will be the causative factors? Number one, it is increase in flow and decrease outflow because of anything. Increase in flow because of increased vascularity, decrease outflow because of the obstruction of the lymphatics, whatever. Number two, increase in the hydrostatic pressure in the body because of any reason, for example, congestive heart failure. Number three, decrease in the oncotic pressure. Oncotic pressure will decrease because if, for example, plasma protein, especially albumin, decreases, maybe in case of nephrotic syndrome or in case of liver failure. And the fourth thing is because of any inflammation or infection, because this causes endothelial injury, infection or inflammation. So these are the various causes. Now very, very important is a classification. The fluid which collects can be classified into two categories. Either it could be a transudate or it can be an exudate. So since we have all studied patho Robbins, we all know very well the differences in a tabular fashion between exudate and transudate. Here again, let's have a review and revision of the same. So as you can see, the transudate, how will it appear? It will always be clear, whereas first I will say T and E, okay? So T is clear, whereas E is cloudy and turbid because there is a lot of protein content, a lot of cells. Sometimes it can be pus cells, lymphocytes, mononuclear cells, and therefore, and also because of increased protein content, it's more of like cloudy, turbid, little frothy, whereas T is always clear. Now coming to the causes, what causes transudate? It is increase in the hydrostatic pressure or a decrease in the oncotic pressure. And number three, it is usually related with some systemic manifestation. For example, there is liver failure, it's a systemic problem. There is renal failure, nephrotic syndrome, that is a systemic problem, and that may lead to transudate formation. Whereas exudate, it is usually because of some infectious inflammatory causes and it is localized. For example, the right lung, the lower lobe of the right lung is having this infection and the condition is pneumonia, and because of that, pneumonia is leading to the pleural effusion. So means it is something localized, that infection or inflammatory foci is localized. It's not systemic, it's not sepsis, So localized, for example, a lung abscess or a pneumonia. or a TB, the Gons focus is present, and because of dissemination of this infection in the lung, this also starts to involve the pleura. Means it is something localized, and usually infection or inflammatory causes there. Now T, coming to this SG, specific gravity will be less, because again the proteins are less, so less than 1020. For E it is more than 1020. The protein content here will be less than 3. Here it is more than 3 gram per deciliter, more than 3 gram per deciliter. Here the fluid, or the fluid which is the pleural fluid divided by the serum protein, when we take out the ratio, it is less than 0.5, but in case of E it is more than 0.5, because there is more, it's protein rich fluid, right, proteinaceous fluid. And coming to this LDH ratio, fluid LDH upon serum LDH, here it's less than 0.6, here it's more than 0.6. So you need to learn, and you need to like remember all of these values. Protein is simple, less than 3, more than 3. The protein ratio is 0.5, so less than 0.5, more than 0.5, and LDH is 0.6, less than 0.6, more than 0.6. The last three things which are having so many numerical values, like the protein ratio and LDH ratio, if these three things are like protein more than 3 grams per deciliter, protein in the fluid divided by protein in the serum is more than 0.5, and if the fluid LDH divided by serum LDH is more than 0.6, if these three criteria are getting fulfilled, it is said as if the Leitz criteria positive, and that always indicates that the fluid so collected is an exudate. So Leitz criteria is having only the last three features, that is the protein thing, the protein ratio, and also the LDH ratio part. If these three things are positive, that means I told you more than blah blah blah, then we are saying that it's Leitz criteria positive, and that strongly indicates that the fluid has to be an exudate. It has to be an exudate, right? Now there is a very simple trick, but actually not that simple, because at the end of the day so many things have to be remembered. But the trick is TB infection miscellaneous. This is a trick of exudates. It is a trick which is encompassing all the conditions that can cause an exudative type of a pleural effusion, and the trick is TB infection. So T for TB, the most common cause of exudative pleural effusion is in fact TB. So the trick is also logical. So it starts with T, that is TB also, which is the most common cause. Second, B is bronchogenic carcinoma. I is infarction, of course, of the lungs, so pulmonary infarction. N is for pneumonia. Here you have to see that N is for pneumonia, right? And F is for fistula, that is a ventricular peritoneal fistula used in hydrocephalus. Ventricle, actually not the ventricles of your heart, but the ventricles of your brain. So fistula, that is ventricular peritoneal fistula. Then E is esophageal perforation. C is collagen diseases, connective tissue disorders, and CABG. Then T is trauma, I is intra-abdominal abscess, O is ovarian hyperstimulation syndrome, and N is numerous drugs. Come on. So again, you can't learn all this together, so you can divide it like TB, do it TB together, TB and bronchogenic carcinoma. Then out of infection, you can remember the first four together like I and FE. So I is simple like infarction, N is pneumonia, F is fistula, and E is esophageal perforation. So you repeat it in your mind or loudly and things will start getting simpler. Infarction, pneumonia, fistula, esophageal perforation. Infarction, pneumonia, fistula, esophageal perforation. So I for infarction, pulmonary infarction, N for pneumonia, F for fistula, and E is for esophageal perforation. Then the left out ones, you do it together. So C is for collagen diseases as well as CABG. T is for trauma. I is for intra-abdominal abscess. O is ovarian hyperstimulation syndrome, and N is numerous drugs. Now in these numerous drugs also, I will ask you one question of the related drug, and you have to tell me the name of the drug. Don't look on the screen. Which drug is used, and it is a very broad spectrum antiarrhythmic drugs and belongs to class 3 antiarrhythmic drugs, which is containing 33% iodine. Yes, it's amiodarone. Okay. If I ask you what is the drug of choice for UTI in pregnancy, nitrofurantoin. Okay. So amiodarone, nitrofurantoin. Right. Now if I ask you a question, which drug is the second drug of choice for pregnancy-induced hypertension. Like the drug of choice we all know is labetalol, but the second drug of choice in case of pregnancy-induced hypertension, it is hydralazine. Any other use of hydralazine? It can also be used in CHF. Okay. Now, if I ask you which drug is used for hyperprolactinemia, you can give me two answers like cabergoline and bromocriptine. But now I say further, this drug is also useful in Cushing syndrome. Now it's cabergoline. If I ask you what are the other indications of bromocriptine, number one in Parkinson's, and number two, it's also used in diabetes. It may be used in diabetes. Okay, and lastly, if I ask you that which drug is useful for malignant hyperthermia management, it's dantrolene. Now, if I ask you another question, that which drugs actually cause malignant hyperthermia, these can be halothane and haloperidol. So haloperidol, it is usually a drug which we study in CNS. But if I ask you, and this question was a previous year's PG question, that this drug it is typically a CNS drug, haloperidol, but is there any cardiovascular use or indication of haloperidol related to your heart? Come on, think over it. Any cardiovascular use of haloperidol? In rheumatic heart disease, it is the drug of choice for managing what? Sydenham's chorea, for managing Sydenham's chorea. Okay, so this is the trick. TB infection. Now coming to miscellaneous. Number one is ARDS and number two is yellow nail syndrome. It's really very weird. Yellow nail syndrome. Oh my god, I've never heard such a thing in my life. Thank you. Whew. So again, exudates for the last time I'm repeating, and let's have an image also. So look at this. Come on now. TB infection, miscellaneous. It is a trick for all the exudates. Okay, exudative type of pleural effusion. So T for TB, B for bronchogenic carcinoma, infection, I is for infarction. Okay, infection. So N first. N is for pneumonia. F is for fistula. Which one? It is the ventriculoperitoneal fistula. E is for esophageal perforation. C is for number one, collagen diseases. Number two, CABG. T is trauma. I is intra-abdominal abscess. Then we have O, that is ovarian hyperstimulation syndrome, and D, that are drugs. I mean N, numerous drugs. And what were they? Amiodarone, nitrofurantoin, then hydralazine, cabergoline, bromocriptine, dantrolene. It's actually like B, C, D. Bromocriptine, C for cabergoline, D for dantrolene. And another one is there, hydralazine. So like B, C, D, hydrated B, C, D. And the initial two are like amiodarone, nitrofurantoin. Some trying to like forcing it to rhyme with each other, though it is not. Yeah. So back to the theory. So TB infection, miscellaneous, we have done. Now coming to what are the, now again there is a big ugly list for all those conditions which can cause a transudative type, this time transudative type of pulmonary effusion, transudative type of pulmonary effusion. Come on, tell me. This time the trick is champion. So the first four letters, that is CHAM, they are easy. For the other two, I've again made this own handwritten cute depiction. So first four, let's learn it here and then we'll go to the images. So CH for CHF and constrictive pericarditis, both of them, CHF as well as constrictive pericarditis. S for hepatic cirrhosis, A is for albumin is low in your body, and M is for myxedema and malabsorption. So C is for CHF and constrictive pericarditis, H is for hepatic cirrhosis, A is albumin low, and M is myxedema and malabsorption. Now other ones I'll tell you ones, but they are really little uncommon and rare types of things and really difficult to remember, like P. Why on earth will you say that P is for peritoneal dialysis. I is iatrogenic, that is extravascular migration of a CVC, central venous catheter. Oh my god, such unlikely things. O, it's for obstruction of superior vena cava. And N is for nephrotic syndrome. Okay, N is for nephrotic syndrome. So now let's have a look at the images. So initial 4 ones you know very well. Yes, so CHF and constructive pericarditis, H is for hepatic cirrhosis, A is albumin low, and M is for malabsorption and myxedema. Now other ones were like champion, P and I. So P and I. P was for peritoneal dialysis. So you can see like this is abdomen and the peritoneal dialysis tube is there, catheter, right? So this is peritoneal dialysis, P and I. I've just made it little like a good wallpaper and nice graffiti to just make it a little out of the box, because what else can I do? Will I make a trick in a trick? Like already the trick is champion. Now further I will keep telling you the tricks in that way. Like, come on, we can't do that. Okay, so this is just to destroy me. Come on, yes. So PI, that is peritoneal dialysis, and I is iatrogenic, that is extravascular migration of CVC, that is central venous catheter. So CHAM, we know